Welcome to the Interventional Glaucoma podcast, brought to you by Elios Vision. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field. In this episode of the Interventional Glaucoma podcast, Dr. Ahmed and Professor Gazzard sit down with Professor Carl Sheridan to talk about the trabecular meshwork and more specifically the myths and misconceptions surrounding it. Let's listen in.
Well, hello, everyone. This is Ahmed from the University of Toronto and University of Utah. It's my pleasure to host this next episode of Interventional Glaucoma. This is a podcast series that Gus and I have been doing, and we're very pleased to have a special guest here. We do want to thank Elios Vision, who has helped support this program. And I'm very excited to talk about some basic science I think is going to be very relevant for the clinician. I'm very pleased to formally introduce my co-host, Gus Gazzard, world-renowned glaucoma specialist and good friend from Moorfields and UCL in London. We all know how much he's contributed to our field on some of the large clinical evidence, and he's got extensive experience in MIGS and other procedures as well. And I think that, as clinicians, we often are really, focused on what's happening with our surgical procedures and in the clinic. But yet so many of our unanswered questions, I think, are really looking to the basic science of how things happen at the TM. So we're excited to talk about this. But before we get into this, I wanted to just hand it over to Gus, maybe just to perhaps intro this topic on trabecular meshwork and its relevance to our field.
Hi, it's great to be back again. And thanks very much for sparing the time, Carl. It's good to have you on board. I think that conventional teachings, it's almost more thinking about how general ophthalmologists, glaucoma specialists think about the trabecular meshwork. And I think we're all sometimes a bit simplistic in how we think about tissues, how we think about medicine. And I think a lot of us make the mistake of thinking of the trabecular meshwork Schlemm's canal system as being a very passive sieve. We think of it as an obstruction, a blockage, and then we do something about that. We kind of go in and fix it. But I think now we're increasingly realizing that it's a lot more complex than that.
We look forward to talking to our special guest, Carl Sheridan of Liverpool, who is a basic science specialist in the trabecular meshwork. He's a senior lecturer in ocular cell transplantation at the University of Liverpool, and is world-renowned for a special interest in ocular wound healing and cell transplantation therapies for numerous sight-threatening conditions. Carl, it's great to have you here. Thank you so much for joining us.
Thank you very much.
Carl, would you like to perhaps give us an introduction to what might be considered an updated view of trabecular meshwork and anatomy, and even some of its physiology and how it's functioning?
Yeah, sure. It's a complex three-dimensional structure. It's a collagen beam, as we know, lined with cells, and these cells are not just passively there. They have a lot of key functions, from turning over the extracellular matrix to phagocytosing debris, nullifying oxidative stress. So they have key cellular functions within that three-dimensional structure. And also, it's a very dynamic structure in that the beams and the cellular TM, it contracts collectively, and the cells themselves must respond to this sort of changing stretch and stress. And this gives it the ability to act like a pump rather than just as a passive structure. And most people don't really appreciate, because we don't really see the TM very well, how much dynamic change there are in the TM structure. And this is a pulsatile flow, because it responds to the pulses. The cells respond not like they do in, say, a cardiomyocyte where they all contract together, more that they respond to the contraction around them caused by the pulsatile changes in blood flow around them. And it's this pulsatile flow and the valves that are involved within Schlemm's canal and around Schlemm's canal, which allow the passage of aqueous to move from inside to outside of the eye.
Thanks, Carl. I mean, that's really interesting. I mean, I love this thought around this complex biological structure having a much more active role in fluid flows and the pulsatile nature and control that somehow it's exerting over these fluid flows. And I think I've always thought that's really fascinating in the context of cardiac pulse cycles and differences in pressure and differences in posture, yet maintaining an intraocular pressure that's safe for the eye. Could you just pick out the main points of those differences that happen in specifically in glaucoma. Do you think we know which is the most important of those changes?
Do we know the most important change? Probably not. It's got to be obviously a combination of many factors. What we do know is that we do reduce the number of cells with age. So we start off something like 750,000 at birth and get to about 400,000. And when we get to about 80, we know that these cells lose a lot of their key functions. So the change the extracellular matrix they make, this impacts on the porosity of the structure. So the 3D pores become more blocked. The structure itself becomes stiffer due to this. We know we lose even more cells in glaucomatous patients as well. So there's like an excessive loss in POAG. And we know that from not just counting cells in cadaver eyes, but if we take Trabs and count those with and without treatments, that was work done way back. They even showed that's a huge loss in cell number as well over that. So it's this collective change in number and function. So we know the cells routinely are phagocytic, so cleaning up debris, but these factors become more dysfunctional. They're less able to do these key things, more so in glaucoma and also with age. And there is this, age is obviously a key player. It's a major risk factor along with pressure in glaucoma.
So, Carl, you've spoken about some of the aging changes that happen in glaucoma and how the pathogenesis of glaucoma accelerate some of these changes in the porosity. A question I've always had, and many of us have, is how reversible are these changes? And is there a temporality of these changes, meaning that do these changes eventually become irreversible? And how much of this is inflammatory versus fibrotic? And this is relevant for us in glaucoma and surgery because we wonder, what procedure do we do when? I mean, we have laser trabeculoplasty, we have, trabecular bypass procedures, other lasers. And if you could just shed some light on that, I know it's a big question to ask, but on this question of reversibility and timing and everything else.
Yep. I wouldn't expect a small question from you, Ike, I don't think. I like to think of it as almost like a decompensation of function. There's no one moment where it switches on and switches off. So there is this gradual decrease in function. Are some of the effects reversible? The answer to that is probably yes. We know that if we can laser the TM with ALT, that there's a portion of cells, likely stem cells, and I can talk about stem cells later, that have the ability to rejuvenate or repopulate areas within the TM. We know that also in the lab, so we can take the trabecular meshwork, we can tease out cells, we can tease out the stem cell population, and we can look for these markers again back in tissue. And more recently, we're finding we've got stem cells residing within the TM, and we can grow them. So we know that they have the ability. What we're trying to do now is unlock that ability or understand the biology more. So that answers the kind of, are these effects reversible? Because we can have this rejuvenated population, which has much better ability to phagocytose than an aged TM.
So that's interesting to me, Carl, because that makes me think that maybe we should be trying to preserve some of the TM in case you guys in the lab come up in 5-10 years time with some great targeted magic bullet that helps those stem cells rejuvenate in a way that I kind of hope that SLT is doing, but that's a bit speculative. We don't know that for sure. I just wonder sometimes whether we're doing our patients a disservice because we're potentially removing a chance from them in the future. If you're going to come up and say, well, actually now I can switch on your stem cells back on again with this targeted viral vector that's going to turn them on and let them do their stuff, maybe we should be leaving some of those guys behind.
Well, yes, I'd agree. I mean, one of the things I'm very keen area of research is looking at transplanting stem cells or cells back into the TM, because we know if we can take induced pluripotent stem cells, make them towards TM lineage and put them into animal eyes, there seems to also be a rejuvenation of not just the TM structure itself, but the local population. So by transplanting cells in, has an effect on the local population as well. And also by removing the TM structure, you're removing everything. You're not just taking out the cells, you're taking away that architecture. And we also know that if you put healthier, younger cells into this architecture, it almost cleans it up. They're more efficient. And so you can recapture I know you said in 5 years' time. It's the standard. You're giving me a task.
I've given you a target. There you go. I've given you a target. But I think it is interesting in the context of us plumbers going out there and replumbing eyes and trabecular meshwork to lower the pressure. I think it is interesting just to have at the back of our mind protection of structures. I mean, one of the adages that I always have for my trainees is, do the bare minimum, do the least that gets you to the end result that you need at the time, because you never know what's coming later, and these patients are going to be around for decades. Carl, what did you think about unidirectional active flows and the role of the Schlemm's canal endothelium? Do we think should we bundle the endothelium in with the trabecular meshwork, or are they intimately involved or very different structures?
I think that's a really great question, because historically we've always thought of them as interdependent. That once it leaves the TM and then gets to Schlemm's canal endothelium, and we have these vacuoles transferring aqueous, then the communication is lost. But we're finding more and more that the cells are communicating with each other all the time. There's cell-cell communication within the TM, but we know now that the TM cells are actually physically in contact with the TM, even those which are more distal than previously thought. So there is this communication, and obviously they're all responding to the same physical environment. And if you have diseased TM in the lab and you interact them with healthy Schlemm's canal, it changes their function. They become less able to form these vacuoles. So the interplay between them is a whole system rather than independent. So I think it's vital that we don't lose sight of that point.
So Carl, I'm just trying to bring it back to the clinician in terms of how does it inform us in decision making? And of course, this is a complex discussion. When do we go to surgery? When do we do laser? What time point do we do this? And some of what you said earlier about reversibility, just coming back to this point as well, I think is interesting. For example, SLT languished for years, kind of, not being popularized because of it being used very late in disease. Thanks to Gazzard's work and others, now using first line, we see that the response rate is much higher. And that kind of ties into a little bit about the fact that there's probably some reversibility if the disease is treated early enough by some biological and other mechanisms that are at play. And at some point, we probably come to a point where the changes become irreversible, stiffness and cellular proliferation and other aspects of porosity. At that point in time, then those therapies may not be sufficient. And this is why medications perhaps fail, other things like this. Could it be that adding medications and reducing aqueous production and everything else, perhaps exacerbating this problem? Could we be actually making in some patients things worse by treating with Band-Aid solutions that reduce aqueous production but don't treat the pathology, and in fact, may malnourish the meshwork and actually accelerate this process? Could that be a possibility that we need to think about changing the way we treat glaucoma?
Yep. I know it's a podcast, but our listeners would have seen me nodding if they could see my face. I completely agree. As a biologist, I don't like the concept of reducing, nutrients to cells that rely on them. So it's sort of kicking the can down the road with regards to the problem, which is at the outflow area. So yeah, I'm fully on board with the concept of treating earlier, because you've got the cells there to treat. The longer you leave it, the more cells you've lost. As you pointed out, then end stage, if the cells are lost and the matrix has become much more stiffer, you're asking a lot more to stimulate that recovery. Whereas if you treat the cells earlier and actually target the problem, which is the TM cells, we know that if you go in early, and similarly, a lot of animal models have always tend to be much earlier, where we see these huge beneficial effects and this rejuvenation occurs. You've got a target. If you're treating earlier, you can actually influence the cells which are there.
So it's almost like we've got a sort of golden window of opportunity after we've diagnosed the disease, but before the tissues have really stiffened up and degraded so much, where we can get in there and intervene early without making them worse with our medications.
So Carl, so actually in reality, you are an interventionalist and you're kind of part of this movement of trying to think about things earlier. Obviously, we have a long way to go, but I wanted to just move it a bit into our therapies today, because the reality is that we do surgery typically later on. This is just the reality of it. And until we perhaps are comfortable with the safety and the paradigm shifts, we're still, in this mantra. We have a variety of different procedures that we use to bypass the trabecular meshwork when we're talking about surgery. We have, stenting approaches, we have cutting approaches, dilation approaches, laser approaches. Do you have any insight, or could you provide some insight into how does trabecular meshwork heal? Wound healing is our big bugaboo with glaucoma surgery. We know with our blebs. What we don't know as much is how does the TM and the canal heal after we surgically intervene with our procedures? Anything you can share on this in terms of how does TM heal mechanically or cellularly or physiologically with these procedures, any of them?
That's a great question, and obviously something we're always researching. So you have an involvement of stem cells, you have a recruitment of cells, just like you do everywhere in the eye. Wound healing tends to be a bad thing. Everywhere in the body, and you get on skin, you want a wound to close, it's great, you move on. You do something like that in the eye, it's nearly always detrimental to vision. Combating wound healing is key, of understanding that a measured wound healing is key to this structure.
I think that how tissues heal are I think, relevant to what we choose. But I have a feeling that, and from what my understanding is, that TM and canal heal differently. These are endothelial line structures. They respond differently. We can see fibroblasts that proliferate from the apical region of the TM and the stem cell region and transform their fibroblasts.
Yeah, well, nearly always the cells undergo almost like this endothelial mesenchymal transition. Once you make that switch, even the Schlemm's canal endothelial cells have that ability. Once they kick into this fibrotic response, it's very hard to reverse. And if there's blood involved and high inflammation, then the fibrosis is more severe, and that reduces chances of success.
So, Carl, what you're saying is that if you can minimize the physical trauma to these tissues, then that's probably in the long term a good thing, minimizing the amount of blood, the amount of inflammatory response that you're causing, because then you're going to get less transformation of these mesenchymal tissues and lining tissues of Schlemm's into damaging fibrotic cells. Is that right?
Undoubtedly, yeah. The more control you have of the wound, the better responses that you have. It's no matter how great a surgeon you are, and I know you are, and everyone else is, things like trabs are very difficult procedures to perform, and there is variation in surgeon to surgeon, and that's why we get differences in wound healing response. And that's not a surgical problem. That's just because we're talking very, very fine tissue.
So, Ike, I'm always interested in how, when I have these discussions with cellular biologists, we're thinking on two totally different scales. There's you go to a meeting and you talk about cellular biology and cell responses and the fact that Schlemm's canal now there's a genetic evidence that it seems to be a sort of lymphatic derived tissue. And then there's Ernst Tam was quoting the other day at a meeting some of the electron force microscopy work showing that there's the stiffness in the TM, which is greater in glaucoma, resides in the juxtacanalicular region, where we also believe a lot of the restriction to flow occurs, and all this really exciting science. And then you and I go into the operating theatre, or the OR, sorry. You and I go into the OR across the pond, and then we start ripping stuff out. We start cutting things with big knives. And I there's always this in my head, there's this kind of disjunction between the two scales of explanation and work. So it's interesting what you're saying, Carl, about fibrosis and scarring. So I think that's an important message from this.
Yeah, very much so. The scale, like you say, I'm at a cellular level, so just like you said with the JCT region, we're talking much smaller scale. So any damage, you're ripping into Schlemm's canal and beyond, these things we can see at a cellular level, but it's much harder at a surgical level if you even factor that in. Yeah,
there's certainly a lot of food for thought in what you've been saying, and we haven't even touched on some of the other research that's out there, like the post-trabecular meshwork, post-Schlemm's canal, angiography work, some of the high resolution work looking at aqueous flow through those aqueous veins, some of the really precise, potentially precise targeting of the now increasingly precision guided openings that we can make in trabecular meshwork. So I think it's exciting times, and we might have to come back and even revisit some of this discussion in a year or two to come. So thank you very much.
I think the more you get to see the TM, the more you get to love it, like I do, and you start to be targeting it a little more gently and appreciate its subtleties. I think that's what will happen in the long term.
Well, there is a Trabecular Meshwork club out there for interested researchers. Just for anyone listening, you can join online. Well, thank you very much, Carl, for your time today. That was some really exciting, interesting insights into the biology, the pathophysiology of trabecular meshwork and how it works, and importantly, I think, how it might feed into our decisions around which devices, which procedures, which bypass procedures we should be thinking of as surgeons and as clinicians. So I'm looking forward to a later podcast when we're going to be able to discuss with you some of the basic physiology and biology of aqueous humor and the other component to intraocular pressure, which is not just the outflow, but also the inflow and the production. So thanks very much for your time. It's great to be back here. And thank you, Ike. And I look forward to seeing you all again.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more information about this episode's topic, read the show notes at eliosvision.com/OUS/podcast. Elios Vision GmbH is the EU distributor of Elios, manufactured by MLASE GmbH, and the FIDO laser applicator, manufactured by Vinert Fibre Optics GmbH. Elios is CE marked and licensed for use in the EU and is currently under investigational use in the US. Please refer to the full disclaimer in the show notes.